Thank you, guys. This is, I'm learning a lot here. So I have a two-part question that's probably has 20 different parts you guys can answer. What do you think the role of mental and behavioral health care, in addition to the addiction health care, plays? I'm clean and sober 17 years, and I've owned sober living homes for 5. So I deal with a lot of new people, and just about every client, over 99% of clients, come with other diagnoses: depression, anxiety, PTSD, trauma. And so it seems to me, I've been in the recovery community a long time, and you hear, well, the person doesn't want it enough, they didn't try enough, they didn't get God, they didn't get something. And I'm sitting here thinking, well, maybe they've got clinical depression, and you take away what they're medicating themselves with, how long can they stay in that condition before they're going to self-medicate again? Then another part of the question is, half of these people are diagnosed in a 30-day treatment center, which, as we all know, they're still shaking the drugs out of their system. They've changed their brain chemistry, and yeah, they're going to be depressed because they're in treatment and they're doing all that kind of thing. How is it that you get treatment to be what it needs to be, which is, I don't know, minimum of 90 days, get a baseline on people so you can get accurate diagnoses and treat the whole person, because addiction doesn't live in a vacuum, or I should say rarely does, if ever.
So Drew, I just want to just jump in there because, it's probably a clinical question, but I can address that from, Chelsea was talking earlier about outcomes. I think that the shift in healthcare, moving from a fee-for-service model to a value-based model, is one that ultimately is going to trickle down to behavioral health, where we are going to be able to show payers, when I say we, I mean people, everyone in this room, this panel, everybody who understands mental health, addiction, what it does to people, the links between it and physical health. I think what we're going to be able to show payers is that 90 days worth of an investment in a day program for substance use and mental health, pays dividends for 25 years and saved, comorbid healthcare costs. I think that's where, in my opinion, focusing a lot on outcomes here, and having been in business for all these years, payers right now are looking at it as, like Chelsea said earlier, how can you tell me that this is even working? What are you guys doing? How do I know, that you're doing it well? And the truthful answer is, we don't have that data to show them that.
And you never will. You're
Well,
never going to have the data saying this person was in for 6 months and look at how it worked.
But the data that we do
1,000.
have is that, and it's just, we as a community of providers and advocates are not doing a good enough job coming together and putting the work that we need in front of the payers to show them, because we do have the data that shows them that money spent in this area of medicine, like I said, pays dividends, exponentially, and saved healthcare costs down the road, and saved productivity costs in the workplace. I mean, it's across the board.
I'm just some yahoo, I'm sober, I work with people, I see what's going on, I can see it clearly, I'm not even a clinician. I talk to people, I hear their stories, and most of the time, they'll tell you their issues started before their addiction issues and other issues.
I think you brought up an important point, that a lot of times, I think the conventional wisdom is that if somebody goes to treatment and they're mandated to treatment, let's say, and they come in with an attitude of defiant individuality, that it's because they don't want it. And most of the time, that's about as far away from the truth as you can possibly get. The reality is that what we're seeing a lot of now is that the reason that this person is defiant is because they've used that as a survival strategy to protect themselves from being hurt. And the answer to that is not to be punitive when somebody relapses or is defiant. It's empathy, love, and compassion, and it's to help them understand on a deeper level that the reason that they are exercising their defiance is not because, they're an idiot, or because, they really just want to get up in somebody's face, it's because they're absolutely terrified. Because of something that happened maybe 15, 20 years ago, and like a football player, they put on all this equipment to protect themselves from being hurt, and they don't even know why they're behaving that way. And so it's, I think it's our job as clinicians to help them see that. And so we see a lot of patients who come into treatment who they don't really even want to be here. Even sometimes they're not mandated by the courts. They're here because, they've got nowhere else to go and they've got a Blue Cross Blue Shield card, And because of the power of group, they see themselves reflected in other people's eyes, and something starts to shift. And what's the difference between somebody who starts to shift and somebody who doesn't? We don't really know. But we do know that the idea of yelling at a patient or scaring somebody into recovery just doesn't work anymore, and I think that was the attitude for a long time in treatment, that you could scare somebody into recovery, and it doesn't work, because the solution to so many of these diseases, whether it's addiction or depression or trauma or whatever it is not punishment. It's compassion.
Absolutely. It's just like you look at the system, you think it's a failure, the failure rate for addiction is high, but you look at the whole thing, the behavioral mental health care, in and of itself, you look at MISA programs, and I talk to people who are in them, like, well, they don't really do much with the mental behavioral health side. And I'm looking at the person going, again, I'm not a clinician, but it seems like that might be primary for you.
We have a long way to go.
Yeah,
I
absolutely.
mean, I just got my degree in social work within the last year, and right, yay me. And it's fascinating because what I've learned in my program is much different from what the people teaching me in my environment have learned, and that's so the new school social workers are getting this compassionate empathy love deal. Okay, we're getting a whole different scope of practice versus what's currently being implemented in the field. So we either have to, kind of similar to maybe what some of the law enforcement and legal system people are experiencing, we have to retrain people, we have to do a better job with training, we have to make sure that we're keeping up with the times, and we also have to really take a look at what's going on in the treatment world right now, where it's kind of like the wild, wild west. I don't know if anybody was graced with the John Oliver 20-minute rant about rehab this week. And I hate to go back to this, but it's a part of the problem. But we have not established a system of treatment that is fair, that is actually accessible and evidence-based, as I've said, and that isn't going to make someone a lot of money at the expense of human rights. And I think that that's where we've kind of come now, and we need to fix it. And it's going to take a long time, and it's going to take a lot of government involvement, and guess what? The veil's been lifted. We know this is a problem now, and the first step is awareness. So there's hope there.